Hello, and welcome to the webinar presented in collaboration with the Connecticut, Delaware, New York, Pennsylvania, Virginia, and West Virginia MGMAs. We'd like to thank today's webinar sponsor, New York MGMA, and their exclusive liability insurance sponsor, MilMIC. My name's Erin, and I will be your host. Today's presentation is led by Greg Cutrona. As the founder of Assurance MD in 1998, Greg has been a passionate and dedicated leader navigating the dynamic healthcare industry. Greg is motivated by the ongoing challenges of supporting physicians with solutions to increase profitability and improve practice efficiency. He is a CPA by profession with almost 20 years of experience in healthcare finance. Community service and giving back satisfy a big part of Greg's energetic spirit. He's an active board member of St. Anthony's Community Center in Wilmington, Delaware. Please welcome Greg Cutrona.
Well, thank you, and I'd like to thank everyone for obviously participating in today's webinar. I hope you get something out of it. I want to start with a story, basically, that I think sort of frames a little bit about today's webinar. And it all involves a call I got one day from, I'll use his name as Dr. Mike. I got a call that he had said that his office manager had just walked out on him, and he was reaching out to me for some help. I knew Dr. Mike for a while because I'd sold some software to him prior to him becoming a client of mine on the managed services side. But he had said to me that he wanted to know if I could come up and give him a quote on how much it would be to help him. So I did that, and I offered to do it for $1,000 a month. And when he turned me down, I realized maybe why his office manager had walked out on him. I took some information back to my office, and I thought I would do a little bit of research on how and if I could help him in some way. Dr. Mike was a small little doctor out on the outskirts of Philadelphia, and he was making roughly around $96,000 a year. I'd done some other practices like his and realized that he should have been making somewhere around $180,000 a year. So I went back to him and I gave him a proposal where I guaranteed he'd make his $96,000 and that we would do something with a revenue share on anything he made above that. Using a lot of the tools that we'll go through in the webinar today, after 1 year participating with us, his revenue climbed to over $250,000 a year. So that's a 160% increase. And again, the reason I tell this story is because it wasn't that we really did anything special. It was just that we were able to use a lot of the tools that we'll go through today to not only identify where lost revenue was, but also use the same tools to make sure that we kept things in step with regards to what we should have been collecting for him. So let me get started, and we'll go on from here. There's a little slide where I think a lot of you might be able to identify where the gift shop revenue sometimes is actually higher than some of our doctors' revenue, which we want to try to change that around. So let me start with what we call the practice profitability portfolio. What the practice profitability portfolio does is it sort of allows us to know where we are going, as opposed once we know where we're coming from. So it's a benchmarking analysis tool, and we believe it's an important step. We do it for every one of our clients, regardless of whether they decide to engage our services or not. Basically, what we do is we measure the productivity, the revenues of practice with like-kind practices in maybe a geographical area or a discipline or an insurance profile. We make observations and recommendations based on the data that we interpret. And our clients know exactly where and what we're working towards. As you can see from this slide, we're basically identifying things like increased collection opportunities, reduced adjustments, increased billing rates, as well as government incentive programs like meaningful use, attestation, PQRS, now it's known as MIPS and MACRA. So obviously, before we get started with many of our clients, we usually like to start with the end in mind, and that's using budgets, forecasts, and goals. So I thought it would be important to maybe just step through the difference of these and how they are used. Budget is typically an estimate of income and expenditures for a set period of time. This may be a monthly, quarterly, or annual. Forecast is where you're estimating things or income and expenditures for maybe different reasons, maybe an extended version of something or a revision that happens based on some event in the practice. And then obviously we have goals. And I like to call our goals dreams with a deadline. These are things that we identify for many of our doctors as things like, hey, I want to add another provider to the practice, or I want to more vacation time, or I want to figure out a strategy to move to retirement at some point. So goals are obviously very important. Our reporting is driven by basically 5 key reports. I don't want to go through them all, but they're basically our daily cash receipts, collection ratios, collection ratio by CPT, days in AR, and aging reports. So in our work, we basically do a daily cash journal every day for every one of our clients, and this is to identify the daily receipts that have been come in and how that compares to what we projected, as well as what we have for the goal for the practice. So you can see this in a granular format with regards to the actual numbers that are being generated, as well as a graphical one, so the doctors can sort of track their progress, again, with regards to what we've maybe identified as the appropriate goal for that practice. Collection ratios are something that sometimes get overlooked by a practice, but the reality of it is that these are very meaningful indices. And in most medical practices, we identify 2 types of collection ratios: a gross collection rate and a net collection rate. As many of you know, most medical practices mark up their billing codes, and because of that, the gross collection rate is actually going to be less than what the net collection rate is, simply by the virtue of the fact that you're most of the time you're marking up your CPT charge amount. One of the things to look out for with regards to collection ratios is that when a collection ratio is too high, it actually sometimes indicates where fees may be too low. So a lot of times we'll see where a collection rate may be actually too high simply because the practice hasn't taken the initiative to increase their fee schedules. And the collection ratio by CPT code does actually, it takes a deeper dive into where there may be revenue leak by specific codes. As many of you may imagine, most medical practices are confined to anywhere from a dozen to 2 dozen CPT codes that they use in the practice. So what we typically do is we will go in and we will look at the most frequently used CPT codes to identify how the performance of those codes measure up to what they should be getting based on some indice like Medicare allowed, maybe expected or contractual amount with a specific insurance company. Once we've identified those CPT codes that are losing the most money, obviously we'll look into why that may be and then do the research and hopefully correct that course of action. Days in accounts receivable is an indice that allows us to measure the number of days it typically takes to be paid in full, or the claim fully adjudicated by both the insurance payer and the patient. A lot of times I like to tell my doctors that when you identify a date of service for a patient, your days in AR will basically be the number of days out that you're fully paid from the date of service, provided that you're billing within a day or two after that. As you can see, the goal and standard for MGMA is around 30 days, okay? With electronic remittance posting and ERAs, this is easily achievable if you're filing in a timely manner. Unfortunately, we see this usually around 90 to 100 days with most of the practices we take into account. The other thing to consider in days in AR is coming up with also what we consider a consistent write-off program. money you're unlikely to be collected, that might be older than a year or two, we obviously would encourage our clients to write that off, because that's going to push this indice up higher than it actually should be. Here's another example of a report that's obviously critical to the practice, what we call our aging schedule. And an aging schedule is basically going to outline the number of how much in terms of either dollars or claims are out there in any given time period. Okay, so MGMA basically says that within the first 30 days, 70% of your accounts receivable should be in the 0 to 30 bucket. After that, 10%, 10%, 10% respectively in the 31 to 60, 61 to 90, and then over 90. Most practices that we do this work for, typically we see a big U, and that's simply because a lot of times practices haven't taken into account maybe a write-off program for claims that are unlikely to be collected. Again, as more time passes, obviously many of you know, it's just more difficult to collect the money that's due to you. This is a good report that we provide, where we actually look at claim denial rates, and claim denial rates would help us indicate, like, is there a problem on the front end? Why are claims being denied? A lot of times our doctors will come to us and they'll say, we need help with the collection of our receivables. And the reality of it is that if you have a high volume of receivables, we believe there's probably a bigger problem upstream with regards to maybe your claims being denied for any number of reasons. We like to sort of make a distinction between claims denied and rejection. Okay, rejections are easy fixes that can typically be done online within 24 hours of the submission of the claim. Denials obviously require more work on the part of the submitter, where it requires some type of a claim resolution and ultimately a claim resubmission. So these are simply claim errors that may result in a denial. This report does not include rejections that may happen and may be fixed in a timely manner. Now, in order to help reduce the number of claim rate denials, we use here a tool called a clinical claim scrubber. What our clinical claim scrubber does is it basically looks for about 14,000 different edits for every claim that we submit. No way could this ever be done by a human being, because basically there's just too many edits that are out there that would need to be checked. So this is all electronically done, and when this claim scrubber comes back, we then will resubmit the claim back to the practice and have them either fix the error that may be out there, or if it's incumbent upon us, we'll just change something for them on their own behalf. But a clinical claim scrubber is a very valuable tool for any medical practice who's submitting claims to both Medicare and commercial insurances. And then finally, we always believe it's important to obviously monitor the performance of our practices, because simply just getting paid isn't enough today. I mean, in order to be competitive in today's medical practices, doctors need what we call KPIs, or key performance indicators, to help them evaluate the performance of their practice. How are they doing with regards to a lot of these indices that we went over earlier? What is their net and gross collection rate, and how are they doing in their days in AR? So there's all types of reporting tools and dashboards that actually can drill down to a granular level with regards to which provider may be causing the problem, or which CPT code may be causing the problem, which insurance payer may be causing the problem. So reporting is paramount to any practice in order for it to really thrive in today's competitive medical market. Now, as many of you know, patients have now come into our practice with extremely high deductibles. And for that reason, we've begun to implement what we call our patient cost estimator. And what patient cost estimator does is it actually identifies the eligibility benefits from a lot of the insured patients, and it actually tells us what will be required of them before we even submit the claim. The value of this is that up front, the practice can either set installment payments for the client if that's appropriate, or many of our practices now are engaging in a practice where they're putting the credit card on file, and once the claim adjudicates through the insurance system, they simply just charge that credit card, similar to the way a hotel may do it if you were staying overnight for any reason. So again, we always say it's good to know before you go. So this is a very valid tool that can be used to just simply help educate the patient with regards to what their responsibility will be for the visit. Online bill payment is a real valuable tool these days, where you can actually go in and have patients receive their bill through an email and actually through a hyperlink securely pay that bill online with a credit card, and it's an e-statement gets sent back with some type of receipt. So again, automation technology just speeds up the process. The more you do that, the more that days in AR indices will just begin to drop down to that 30-day level that we've talked about earlier. I can't leave out people. I mean, a lot of you know that there's a lot of people who actually are behind the scenes who do these things. In our office, we have certified billers, people who are bilingual who can talk to the patients regardless of what background or language they speak. And again, we're very blessed to have dedicated employees and services, as most practices do. So being customer centric, I think, is extremely important to not only the medical practices that we serve, but also the medical practices that serve those patients. And there's nothing, and this chart just basically kind of walks us through a lot of the things that we've talked about already. But the revenue cycle is a defined process, and we believe that if you follow this process and this cycle, you will probably become more successful in your practice than you otherwise would be if you leave out any one of these components. Well, quickly, I'll talk a little bit about claims clearinghouses. As many of you know, there's a number of them out there on the marketplace today. We use a lot of tools in our claim clearinghouse to do things like eligibility, front-end payment processing, managing claims within a 24-hour process, lockbox services, ERA solutions, denial management, as well as patient statement management as well. So having a good claims clearinghouse can be a valuable tool to any practice in order to sort of bring together all the pieces of that revenue cycle management that otherwise might be part and parcel without it. And that concludes my presentation. I'm happy to answer any questions that anyone has.
Hi, Greg. We have a question here from Keith that I think you can, if you open up your chat box there on the back side, Greg, you'll be able to see the Q&A. But the question from Keith is the cost estimator available online for practices? We've been looking for a good one and have yet been able to find one.
It is available. It's a tool that we build into our clearinghouse option, only because our clearinghouse option builds the database of a lot of the fee schedules that either the practice is billing for and what the EOB send back as allowable amounts. So it's using the doctor's own data to actually calculate what the patient may be responsible for. So it's not it's not a universal tool that simply uses data from the public domain as much as it uses data from the practice specifically. I'm not sure if that answers Keith's question, but how it works.
And Pam asks, how do we go about getting profiles of other practices for comparison?
That's a great question. As a company like Assurance MD is that we have obviously data from other practices that we serve. So we sort of mine that data in some way, and when we have a like-kind discipline that we're maybe doing a practice profitability portfolio for, we'll pull that data from that existing practice. I don't know if I have an answer for you with regard to how you would do it in your own area. What I would encourage you to do is maybe reach out to your own local medical society. I know that they have resources locally for us for a lot of the practices that may be participating in those. But unfortunately, in the absence of getting data from other practices, what we tend to sometimes rely on is information that may be in the public domain, such as the Medicare allowable or contractual amounts by large insurance companies.
Thank you all for joining today's webinar. If you're a non-member, please consider becoming a member of your respective state affiliate. This concludes our webinar. Thank you for your participation and have a wonderful afternoon.